Lori, I can't hear you.
We cannot hear you, Lori.
Okay, can you hear me now?
Yes.
Yes.
I don't this headset sometimes does that. It's so annoying. Sorry about that, but welcome everyone to the Acme stakeholder meeting. Today we have Dr. Len Fromer, who is from Turner Impact Capital. He's responsible for the oversight and leadership of their healthcare initiatives. He's a nationally recognized expert in the areas of primary care practice redesign and transformation, integration of behavioral health and primary care, quality improvement and outcome measures, vaccine compliance quality improvement, and health system reform. He has served on the American Medical Association's Commission on Healthcare Disparities. He was a practicing physician for over 28 years and previously served as executive medical director of the Group Practice Forum, where he led nationwide projects to coordinate care across a continuum of services, including preventative, outpatient, inpatient, acute hospital care, post-acute care, and palliative care. Len has lectured extensively on the topic of health system reform, the patient-centered medical home, and the accountable care organization, and has been featured on NBC, ABC, and in the New York Times. Len has served on numerous boards and advisory committees for, among others, the American Medical Association, U.S. Department of Health and Human Services, World Foundation for the Study of Female Health, American Academy of Family Physicians, the Annenberg Center for Health Sciences. He received his BA from the State University of New York and his MD from State University of New York Downstate Medical Center, and completed his residency in family practice at UC Irvine Long Beach Memorial Hospital. So with that, Len, I will turn it over to you. And before we start, one other thing, do you prefer us to ask questions as we have questions, raise our hands, or wait till the end?
Any way is great. I'm happy to stop and answer a question as I see it come up, or we can wait and do Q&A at the end. I'm flexible, so whatever people feel inclined to do is fine. But I'll certainly, my plan is to go through some slides, tell you all about our company and our fund and what we do, how it relates to what your organization is about. And the slides, I think, will probably take about 30 minutes most. So
Okay.
we should have nice time for Q&A and discussion.
Okay.
Greetings, everybody. Good afternoon. It's great to see some familiar faces among the crowd, and great to meet the rest of you virtually. I'm going to tell you a story about what I do now after being a family physician on the front lines, serving patients in a mostly underserved environment here on the west side of Los Angeles. A lot of Medicaid patients, a lot of patients with no insurance coverage, and a lot of patients, especially at the beginning of my practice career, who had serious behavioral health problems that led me to really work for a long time to integrate physical and behavioral health services. I know you are all sensitive to and can relate to the fact when I tell you we weren't even allowed when I started practice to have the behavioral health medical record and the physical health medical record for a given patient in the same location. They made us keep them completely separate. It was nonsense. It was crazy. So a lifetime now of working to try and get that all integrated, improving the quality, access, availability of behavioral health services and care for patients that we all love, know, and see and have in our families. So let me start by sharing some of the slides. And if technology is friendly today, it's Tuesday, so it should be friendlier because Monday is the least friendly technology day in my life. So let's see what happens here. Tell me if you guys can see this. Are you
Yes,
seeing my screen?
yes.
Great. So what I wanted to do was give you this quick background to what we do and how you should think about us as a company and a fund, because it will lead to the demonstration to you of how that makes such a difference and improves the access and quality for patients with mental health needs, and how we can possibly rethink how we build that infrastructure that's necessary for patients to get the care they deserve and a place for that to happen. So think of us really as an infrastructure solution, the bricks and mortar that are needed for patients to live in while they get care, whether that's concurrent, sequential, but you'll see as the story unfolds how that played out in our fund. So Turner is started about 12 years ago now. It says 2014, but really the genesis of thinking about what the company was going to be all about really started about 12 years ago with the principals thinking about what are the great social challenges that face Americans, fundamental social challenges. And the three pillared foundation for what our mission is focuses on education, housing, and healthcare. Those are the three pillars to us that without all three, people having access to high quality education, a place to live that's stable, that they love going home to, and access to high quality healthcare, that's fundamental. So the first fund that we formed all around 2014 was the Education Fund. And to date, in 10 years since then, we've raised enough money and used that money from investors to build 118 charter public schools around the country. Those charter public schools serve about 60,000 students a year. And if we were a school district, we'd probably be the 25th or 26th largest district in the country. So a huge footprint in terms of that. Every one of those schools are in neighborhoods and communities that either did not have any public district school and the students had to go by bus to get to one, or they had a failing public district school. So we never compete with the public district schools. We augment where there are spaces, where there's problems. And I'm happy to tell you that the graduates of those schools, they're K through 12, the graduates, we track their graduation rates, virtually 100% graduation rates from high school. And then we track where they go to college, how many of them complete college, and then, very importantly, where they go back to when they start their careers. And overwhelmingly, they go back to where they came from, the original neighborhoods, the underinvested, underserved neighborhoods, to make a difference. We measure in all three of our funds, we measure key performance indicators, things like graduation rates, college completion rates, statistics that tell a story about whether or not we truly are making an impact. And we do, in fact, we're very proud of the scores we get and the impact we make. The second fund we started about 8 years ago is our housing fund. And the housing fund, again, targets underserved communities where it's really difficult to find affordable workforce housing. So imagine garden apartment complexes or single family home clusters where people can afford the rent, people who fall kind of between voucher housing supported by the government, and affordable rental housing that's not supported by the government. So our mission for the housing fund is that we keep rent low enough so that it never represents more than 30% of the family take-home pay for their living quarters. And that has led to now about 11,000 housing units around the country where families live, again, overlapping with that same underserved community definition. So we use demographics to kind of define where these housing campuses are. What sets them incredibly unique in the world of real estate development is that in every case where we have a housing property, we put an enrichment center right in the middle of the campus. And that enrichment center offers free programming to people who live there in the campus, on the campus. They don't pay a thing. It's part of their rent. Programming that includes things like financial literacy education for the parents, healthcare literacy education for the parents and kids, after-school tutoring for the kids who need it, health screenings for blood pressure and diabetes and vaccine clinics, safety programming so that the living environment is safe and the perimeter is controlled, and community watch programs that are launched. All of that in total last year, about 69,000 hours of programming across the land, coast to coast in those centers. All of that is free, and it is created, the curriculum is created and taught by volunteers who live in the community, live on the campus, in the apartments. And in exchange for them doing that development of the curriculum and teaching, they get free or reduced rent, depending upon how many hours they put in. So it's a wonderful model that is designed to do one thing, which is to completely flip the landlord-tenant relationship. We're the landlord. The tenants who live there double and triple the average length of their tenancy before they move somewhere else. In America, in multifamily housing, the average tenant family moves every 2 years. So we try to double and triple that because that turnover rate, relatively high in standards around the world, the turnover rate of every 2 years average is very costly for landlords. That's the single biggest cost on the balance sheet is tenant turnover. So by us being able to rapidly extend that because of the improvement in the services that are available, the physical plant that we fix up, we're able to keep rents low and below that 30% threshold. About 6 years ago now, we started our healthcare fund. And the healthcare fund, in the same communities that, imagine a Venn diagram with all these overlapping spaces and geography where we put these bricks and mortar and facilities, the healthcare fund targets federally or state designated health provider shortage areas, or another designation that the government uses is medically underserved areas. So HPSA, health provider shortage areas, MUA, medically underserved. With that designation, we can look to locate healthcare facilities that we partner on with high quality healthcare providers in the behavioral health or physical health space. And we synergize as much as we can because we're geographically overlapping with the other two funds. We try to synergize function. What do I mean by that? The teachers who teach in our charter public schools live in our workforce housing and get their health care from the partners we do the healthcare fund with. The healthcare workers who support the people in the white coats in the healthcare facilities, the physicians, PAs, nurse practitioners, the teams that support them, front office, back office staff, they live in the housing and so forth and so on. And they offer the healthcare programming on those enrichment centers comes from those teams. I'll also tell you, much to our surprise, we found out that young doctors who had large student loans to pay back, to our surprise, were very interested in living in the workforce housing also. So we have them, and they're helping to develop the curriculum in our programming. So it all just fits together like a puzzle and works beautiful magic. All three of the funds, like I mentioned, track key performance indicators. For the healthcare fund, for instance, we track things like access. Is it easy for patients to get access to their healthcare provider? How many visits per year do they have? How many minutes per visit do they get? What is the rate of hospitalizations? Do we keep people healthy and well and stable so they don't end up going into the hospital as much as average for a similar population? Lengths of stay, hospital readmission rates, and so forth and so on. Most importantly, I think for you is we track functional status of patients and various KPIs, key performance indicators in the behavioral health space. And we do assessments of the patients much more than what happens in the average for healthcare behavioral health facilities to track almost on a daily basis global functional status for the patients, make sure that things are working, they're getting better, the access they get to care is leading to great outcomes. So that's kind of the background story. If you look at the map of the country and where our dollars are invested, we have a predilection, even though we're coast to coast. You can see by the numbers here that we have a bit of a predilection for the West and the Southwest, particularly Arizona on there where you see the map. So, you know, we're a national footprint with a lot of activity in a lot of those schools and a lot of the housing and a lot of the healthcare in the Southwest for sure. Let's take a look at the fund that I'm in charge of, the Turner Healthcare Facilities Fund, the third of our three verticals, as we call them. And how does the model look? How does it work? So we are a build-to-suit infrastructure solution. What it means is we gather money from our investors, and the investors in our fund, and we keep the fund separate, by the way. There's no mixing of the money with schools and housing or housing and healthcare. Each fund has a separate money raise. And the investors in our funds run the gamut from foundations, community and university endowments, union health and welfare funds, banks, high net worth individuals and families across the board, a very good mixture of all of that. And we pool all the money into what's available for each iteration of our fund. We're on healthcare fund number 2. We raise enough money in healthcare fund number 1 over the first 4 years of our 6-year existence. Healthcare is our baby, as I told you a few minutes ago. We raise enough money in that first iteration of healthcare to build about $390 million worth of healthcare facilities. That translated to 34 different facilities across the country in different states, a lot in California and Arizona, that run the gamut from primary healthcare centers, community health centers, to program of all-inclusive care for frail elderly, to behavioral health facilities specific for behavioral health, to medical respite and temporary housing facilities. So very broad spectrum. I'm going to focus on the behavioral health facility that we have in Phoenix, and we're, as we speak, about to open number 2. I'll focus on that in a few minutes. But you see here, the model is we have that money to provide to partner clinical healthcare enterprises, behavioral and physical health enterprises, who partner with us where we provide the capital up front. They don't have to put out any money. We provide the capital up front to develop, find the real estate, develop the facility, hand them the keys, and then in exchange for us providing up to 100% of the capital that's needed, the provider organization signs a long-term lease, and the rent payments on the lease is what generates the return to our investors. That is as simple a description of the model as I can make it. I know there's a lot of questions inside of that, but that's basically what it's about. and it's a very transparent, open process for the clinical partners that we work with. So they see every line of the budget, because that budget that it costs us to open a facility with them is what the basis is of what the rent's going to be. We take the total budget for the project, multiply it by a rental rate. That rental rate is derived from a clinical and a financial underwriting process, essentially credit risk underwriting. And then we land on a number that becomes the multiplier against the basis of the driven by the cost of the project. And that's the rental rate per month. We always want to have sustainability of these facilities and the enterprise that's taking care of people in them. We want long-term sustainability. So we seek 15 to 20 year leases with 2 5-year options. We always offer a purchase option that if the clinical organization wants to purchase a facility from us after we build it, they can. And it's again simply driven by and at the total budget cost for the project. So our mission leads to us offering those purchase options, not at fair market value, but a much better deal at the original budget price. Again, completely transparent so that the purchasing organization, clinical partner, they know exactly what's driving the basis cost. We can get into Q&A about how that all, the little nuts and bolts under that, but that's basically what we're up to. So what is our value proposition? What differentiates us from other developers out there? How are we different in the world of developing solutions in all 3 of our verticals? But let's focus on healthcare. First of all, the facilities are built to suit. We don't speculate. So we won't go out and find what we think is a great location in Phoenix, secure the land, purchase, or if there's already something on the land that can be made into a medical office, we don't purchase it first and then go to the healthcare market and say, who wants this? Look what we have. That's not how we do it. We will not purchase land or build anything without a healthcare provider first coming to us and saying they want to have a facility and here's where they want it to be. And they'll usually give us maybe 5 zip codes, but they generally focus in on what part of the geography down to the community level they want to be in. We then go from our in-house real estate division, we find land that's either ground up, it's just bare dirt and we're going to build something, or more likely, about, I'd say 75% of the time, it already has a building on it, and we do adaptive reuse of what's there. And through a series of design meetings, starting right from the beginning of what their vision, the clinical enterprise vision is of what they want that facility to look like. How many rooms should it have? How are they going to do face-to-face versus virtual care, or both? Are they going to do individual visits only or group visits? I'm thinking about a behavioral health facility at this point. Is it going to include housing along with when a person's getting an intervention? Is it going to be temporary housing? Is it going to be semi-permanent? Is it going to be permanent housing? So all of these things are very much in depth discussed and figured out in a series of design meetings. We have in-house design folks. We work with local architects. We work with local general contractors. We work with local subcontractors. The clinical organization we work with can get involved as much or as little as they feel comfortable with. If they need us to supply those experts and points of view and skill sets, we can. If they have their own, we can work certainly with them. But it's from beginning to end a solution that is unique each time. It's not a rubber stamp, one size fits all. It's built to suit exactly what the clinical enterprise wants. We prefer to do programmatic rollouts. What does that mean? So what it means is we would like an organization that comes to us and says, we want you to do our first expansion over here. We want to sign an agreement with them that says, if they like us, we're going to be their developer of their next 10 facilities, let's say. So we've got in that 34 in the original fund, I'm thinking 6, 12, 14, 18, about half of it was programmatic. It wasn't one-off. So we had the ability to recognize financial and efficiency and operational efficiencies when you do something like that. The financing solutions take two forms. As I described to you, we can provide 100% of the capital, start from scratch, build something up from the ground up, or adaptive reuse. But what we also do, if it makes more sense for an organization, we have behavioral health provider, for instance, will come to us and say, we already own some real estate. We want to free up some cash on our balance sheet to do operational expansion. We can buy that facility that they own already and lease it back to them, freeing up the capital that it's worth to allow them to have money for what we call OpEx for them to expand. And then they can buy it back to us on those terms I mentioned earlier. That's called a sale leaseback transaction. So we do both of those things, whatever fits and works the best for any given organization. This build to suit proposition that I talked about, if you break it down to its parts, I mean, what is it all about? We sit and discuss strategy with some organization who comes to us and says, here's where we want to be. This is what we have as the vision strategically of what we want to do and serve the patients. Let's talk about the strategy to accomplish that, right? Just exactly where out of the 10 parcels we find in a given set of 3 zip codes that an organization says to us, we want to be in there. What are the best of those 10 or top 3 or top 5 out of the 10 based on, do you need curb appeal? Do you want to be in a residential area? Do you want to be in a more industrial area? Do you want to have a hospital next to you? Do you know, a lot of questions about the strategy of strategically thinking through how do you want this operation to look 5, 10 years down the road. We have the nationwide experience, the people who are in my internal real estate division, our construction management division. These are guys and women who have been doing this for 30 years. And they have this wealth of expertise that translates into best budget, on-time delivery, on-budget delivery, just extraordinary success in delivering value. Once we know where we're going to try and be based on a given parcel, what's the best option for that organization, we buy the land. So we do a purchase sale agreement with whoever owns it at the time. We purchase the property. We here at Turner, our fund, purchases the property. And then we begin that design process I mentioned to you. So beginning to end, starting with high-level strategic ideas of what it should look like, all the way down into drilling down into eventually with the architect who they select. How many exam rooms are they going to be? How are we going to do the patient rooms for interaction? If there's going to be counseling, if there's going to be group sessions, how is that all going to look? What size is each room? Colors, furnishings, you name it, everything. If it's a temporary living or permanent living situation, what are the homes going to look like? How many people are going to be in each one? What kind of staffing is going to be in each home? Those kinds of questions all get into that design process. Once that's finalized and we have final construction drawings ready to go, we have to get approval, permitting, all the approval from the jurisdiction that the facility is going to be in. And then once we get that, we start construction. On average, our construction times, if we're going to do ground up, it's usually about 12 months from first shovel in the ground till certificate of occupancy. If we're going to do adaptive reuse, they generally run a little faster. It's about 9 months. So we're quick, we're efficient, we're extremely value conscious in the cost of these budgets. Our guys have so experienced their pipeline for inventory and supply. They've been doing this so many years, and they can solve solutions that are costing more and more money every day now. And you should have seen them shine when COVID hit, and you had to get really, really creative on how to get your supply chain fulfilled in a time when the world was locked down. But I'll share something with you, and most of you probably have personal experience with this. The utility industry in America is not exactly the most efficient and success-oriented industry to work with. So if you're trying to build something and you go to an electric utility and you say, we need to put in a new switchboard for linking the grid to the facility because we're going to be increasing the electric demands and we have to expand it. So we need new switchgear, it's called. Well, most of the utilities in America, your answer is going to be, great, we can do that. Get on the waiting list and we'll get back to you in 3 years. I might be exaggerating a little bit, but I think everybody on the call probably knows what it's like dealing with the semi-regulated public utilities. Instead, what we've done, because we know that's a critical flow time-wise in getting our jobs completed on time, we have sourced switchgear from around the world and then warehoused it so that we have it ready when we need it. And the construction guys say, I need the switchgear. Here are the specs for the project we're doing in Phoenix. And the answer we get from our property management division is, I can get it to you in 2 days. Where are you going to put it? Big difference, world of difference. So just that's part of the great value that we bring. The lease that I was talking about, it's not like your typical apartment leases. We're talking about a 75-page document with lots and lots and lots of things in it, including reporting requirements for the key performance indicators. So what does that mean? What are the metrics that we're going to measure around patient outcomes, patient access, around patient satisfaction and family satisfaction? We track all of that. We also are very environmentally conscious. We subscribe to the United Nations set of successful development priorities. There are 19 elements of that document that was signed on to by every country in the world. And we go through every one of those 19 pieces around, the labor rules and regulations that we ascribe to, the kinds of materials that we use, what do we do with the materials that we're taking down if we're going to be doing a ground up? Where do we remove them to and handle them appropriately for the environment? And we give ourselves a score. So we have an independent national agency that is in the business of looking at a property before we touch it, and then after we get done with our development, and giving us a grade before and after. And we're happy to say that across all of the environmental, sustainability, you name it, every kind of metric you can think of in terms of the actual bricks and mortar and facility and land, we improve that score pre and post. I think the last time we looked was in the spring, a few months ago. Across all of our facilities so far, we've improved them 54% on average for each facility. So we're very proud of that. That includes water usage, electric usage, solar questions around sustainable energy supply, wind, solar, and so forth. What about the organizations that you have to interact with, you, your families, your patients? What about how do we support the long-term success of the providers of the services that you and your families are getting from these clinical organizations that we partner with? So how do we support that? Well, first I mentioned to you in-house real estate, prime location, the right function happening in the right location, the layout customized, built to suit, unique, and the best one for what's necessary in that facility. Human resources, we manage all levels of the development process, identification of the site, entitlement, zoning, permitting, design, budgeting, and construction. If you need us to do all of the human resources, we can. If you have your own and we need to help, we can. We can leverage all that to support the people who are the healthcare professionals and the teams supporting them. We're a firm, big believer in patient-centered, team-based collaborative care. That's our mantra. Patient-centered, team-based, collaborative care to get the patients what we call the quadruple aim results. 4 things: great outcomes, great patient satisfaction, great population health statistics around cost of care, and the 4th piece, everybody working in that environment has to go home at the end of the day happy. So the satisfaction of the workforce is critical to us. So that recruitment and retention of teams taking care of the patients is successful. So here are some examples of the kinds of places that we built, just to give you a visual. We're going to focus a little bit on the bottom right, which is a facility in Phoenix that I want to talk about. But, you know, across the board here, what you see are program of all-inclusive care for the elderly, combined with community health centers offering behavioral and physical health services in the same building. The first one there is a family federally qualified community health center in El Cajon, California, near San Diego. The organization, San Ysidro Health, partnered with us. It's a really interesting project because it's on a slight hill. And the side you're looking at during construction there was the downhill side, in which the ground level is the PACE center for frail elderly. Walk right in off the parking lot. The uphill side on the other side of the building is what you see here is the 2nd floor, and that's the community health center. So all ages, you know, birth to death, primary care, physical health, behavioral health. But that uniqueness of 1st floor, 2nd floor is important because for the frail elderly population, the mobility issues become critical, and you want them on the ground level. On the other side of the building, people can park and walk straight in, and they're on the ground level for the primary care community health center. Likewise, the middle upper picture here is Neighborhood Healthcare, a federally qualified community health center in Riverside. This was their first PACE center on the 1st floor, community health center on the 2nd floor. That building used to be an office building that we converted into this beautiful health center with a central open courtyard that you can see, get a little snippet of there in the middle of the roof, that opening. On the right, that's a pure PACE center for WellBe Health. New on the scene, national footprint, PACE operator for taking care of people in this wonderful program of all-inclusive care for the elderly. It's a great national secret, but we're trying to make it less of a secret. We've built more PACE centers now than anyone in the country in the last 5 years, and we need much, much more, many more of them. Imagine a combined adult daycare center and medical clinic in the same building. And then you're off to kind of understanding what PACE is all about. On the bottom, you see several Medicare Advantage clinics for the not as frail, low-income elderly. Oak Street Health, a national provider now part of CVS, and ChenMed, an independent provider of services to the frail, low-income elderly. So on the lower right, New Freedom, this is a behavioral health program specialized in Phoenix that we were approached by a well-to-do family who wanted to change the footprint or the image or the experience of what happened to people coming out of incarceration. What did they go through? What led to such a high national recidivism rate and how could that be impacted and reduced. So they came to us and said, we want to be in this part of Phoenix. They pointed to a part of the city, find us a site. We wanted to do adaptive reuse and create a campus where on that campus, all of the services that someone reintegrating into society had available right there. They didn't have to go all over the city to get housing placement, vocational training, parole services, on and on and on. So many of the things that led to failure and recidivism. So what we did was we found a hotel that, as you see in the picture, what, 1, 2, 3, 4 stories high with a big central atrium. I believe it was a Crown Plaza that was impacted by COVID when lockdown hit. And we bought it and we closed down the hotel and we created what I described as this behavioral health campus. The rooms of the hotel became a dormitory for about 375 patients at a time, where they come in from coming out of prison and they live in the facility for 90 days. And during that time, they get intensive individual and group counseling, psychologic and psychiatric services, physical health services are available if they need a doctor's visit for physical health problems. They get vocational training. They get permanent, 100% of the graduates of the program get permanent housing placement. It's just a huge success. To this day, we're now 3.5 years since it was opened, and they run full all the time. 3.5 years out, their recidivism rate has dropped 92%. Absolutely changing people's lives dramatically. And we're really proud of that program. It is paid for by Medicaid dollars. The state of Arizona has a Medicaid waiver, so they're allowed to use Medicaid money for the things that really determine patients' outcomes, social determinants of health, all of the things we're all thinking about that matter greatly in getting people back on their feet, getting people successful futures. It has been fully subscribed almost since it opened. So we are about to close on, which means hand over the keys to, and get a certificate of occupancy on their second facility, which is about a mile from this one that you're looking at a picture of. And it'll relieve, it's a relief valve for some of the patients that are needed. Here's some kind of statistics around the typical facilities we opened. This is ground up development. This is the combined PACE and community health center I talked about in El Cajon. And here you see what it looked like to build. It's called tilt up construction. We went, what was there was a closed down car dealership that we demolished, environmentally sensitivity wise, got rid of the material that was there for that, started from ground up and built this facility, a beautiful healthcare facility. Here's a ground up development of the primary care center. That's a ChenMed center. I think, again, beautiful facilities. You'll see that this is about 10,000 square feet, this one. And then here's the ground up development of a primary care only center. Again, tilt up construction. And here's the kind of explode out of the details around this New Freedom Center. One of the things I would point out is we found the correct hotel because what we needed was a cluster of buildings at the bottom of the 4 stories around the bottom that was essentially a mini convention center. So imagine a hotel that has a meeting space, sophisticated kind of meeting space, and that became all of the treatment facility space for the counseling, for the training, for vocational training, for permanent housing placement, the parole services. They were doing such a great job. And one of the vocational training things that happened there successfully was training of big rig truck drivers. They had contracts with shipping companies, trucking companies to train drivers. It went so well, the Arizona DMV came knocking and said, can we open an office of the DMV in your building, in this building that we built? And we would have done it. I mean, it was incredible to be asked to do that, but we would have done it, but there was no space. Too much else was going on. So you see some of the atrium elements there of the inside of the lobby, just a wonderful success story, changing people's lives dramatically. So that's what I wanted to talk about. I'm sorry I went a little longer, but there we are. Happy to answer questions, anything about the model, the strategy. I am all yours. Lori.
Okay, so there are questions in the chat. The first one was, what does PACE stand for?
Program of All-Inclusive Care for the Elderly, PACE. It's a national mixed Medicare and Medicaid program, federal government and state governments. The patients and their families pay zero if they have dual eligibility for Medicare and Medicaid. It costs nothing. It's paid for out of the Medicare and Medicaid programs. And it is fantastic. Patients come and go. They don't sleep there. They go home every night. They're brought to the center and brought home and brought to their medical appointments in the community with transportation that is provided by the PACE operator. They get adult daycare services all day long, and then they get medical visits in a fully functional medical clinic with extensive behavioral health interventions. Many of the patients have mild dementia, and there is a therapeutic program for that, not just custodial care. So it's just a terrific program.
We visited that, so we did tour it, and it was impressive, the New Freedom original one that you saw. Now also name a few facilities. I think you just did the New Freedom. And again, you mentioned the waiver, but we only have the SUD waiver from IMD. So are these people coming out of prison and they're getting paid under the SUD waiver for IMD?
The patients get on Medicaid. And once they're on Medicaid, the Medicaid dollars, the New Freedom program can bill Medicaid for the services that are being provided under typical CPT billing codes. Part of that is substance abuse treatment, intervention for sure, but not all of it. Some of it is, the patient might have longstanding behavioral health diagnoses, and they get treated, they get diagnosed and treated under those codes.
Okay. Now, also, when you talk about buying a property and then licensing, let's just say if you had an interest and had a provider to do secure behavioral health residential, so secure births, they have to be under 16. So I would imagine maybe a cluster of them in a neighborhood or something, or a campus. How would you go about canvassing for licensing, or would you buy a property and then try to do a community outreach to change the licensing or something like that?
Yeah, great questions. So as I mentioned earlier, we don't speculate. It's the nature of our fund that we are very avoidance oriented. So what we would do is we would have a provider who had the vision for what you just described in terms of a footprint, bricks and mortar, a cluster of homes, come to us and say, here's what we want to do. How do we do this? We have options because we're unique as a developer in that we have our housing fund and we have our healthcare fund. So there's a nice overlap there. Think again of the Venn diagram and the space where the two circles intersect, and be able to say, well, what can we do with our housing fund money in terms of the campus that can be built, a cluster of homes, 16, maximum 16 patients in a given facility, but think of a cul-de-sac, right? And you have 10 homes on a cul-de-sac, each with 16 maximum, and you then have a center. We would put one of those central enrichment central areas for events, for programs, for central kitchen, for, whatever was appropriate. But the physical layout, we would work with a provider in Phoenix who said, here's what we want to, and here's what we envision. Can you build it for us? Or can you buy properties that would form a cluster like that around a cul-de-sac of some such thing of that nature?
Also, you talked about the recidivism rate for New Freedom is they're doing really well, but with only 90 days of treatment, where do they go from there if they are maybe have felonies and the cost of housing in Phoenix and the cost of rents are so high? How do they step down and still maintain, their both physical health, behavioral health, substance use avoidance? How does that work?
Another great question for sure. So as I mentioned, 100% of the graduates of the program at the end of the 90 days are in permanent housing placement. And 100% of them have a job. So right off the bat, that's so vastly better than anything else out there as an alternative to something like that program for former prisoners. So how do you maintain that? The patients get plugged into permanent care patterns, behavioral health patterns, and physical health. The New Freedom program happened to choose a community health center that was maybe 10 blocks away from that location. We visited it with them. We met with the leadership and said, here's what we want to do at New Freedom. What can you do after they leave New Freedom to continue interventions with these patients? And they embraced it wonderfully. Again, big secret in America, community health centers, that program, which has been around 75 years now, almost 75 years, 50, let me think. No, 55 years. In America, there are 1,600 community health centers in like 12,000 locations around the country. And they are guided by federal law because they get enhanced reimbursement for care of patients than they'd otherwise get if they also agree to take everybody who walks through the door. They can't say no to a patient who walks through the door because they don't have insurance coverage or some other reason. They have to take everybody. They have become the backbone of high quality, great access care to millions of Americans, millions. Community health centers take care of 1 in 10 Americans now across a country of 330 something million people. 1 in 10 is cared for in a community health center. So New Freedom signed an agreement with that community health center near them. That's where the patients, when they leave New Freedom, continue to get their care, physical health and mental health.
And
Go
okay,
ahead.
you said that all of them had permanent supportive housing. That's a big feat since we have a wait list in
Yep.
Arizona for housing vouchers. Did you guys provide additional housing, or how did you get these hard to get housing vouchers?
The New Freedom people could answer that better than I can, but my understanding is from working with them constantly over the past few years, they work hard to create arrangements with housing developers, housing providers across the board in the Phoenix MSA, Metropolitan Service Area. And through those connections and arrangements and real, hard work by the team at New Freedom, working every day of those 90 days they have that patient there, so, solidifying that they will have permanent housing when they leave.
Okay. Now, Rachel, you've had your hand up.
Hey, yes, thank you. So I've known graduates from the New Freedom program and they're doing a great job there. So I'm a big fan. Again, that one, so to me, it's a lot more targeted to the post-incarceration community and is operating under that SUD IMD waiver. We badly need, but we don't have an IMD waiver for SMI. I would love to see a program like that for SMI with staff, doctors, nurses on site. And like Lori was talking earlier, there's, in Arizona, it would have to be a group of houses with different addresses to have 16 people in in one building and create a network of a community. It's the only way we'd be able to operate something like that. Are there any of your facilities in other states that have SMI IMD waivers that are operating? So that's question number one. And then question number two, the source of income for these programs appears to be Medicaid, basically, hence the IMD restrictions. There's some programs in California, for example, that are partially funded by their counties. For example, Synergy. Do you have any facilities that you've created that have county funding or another source of funding besides Medicaid dollars? So 2 questions.
Got it. Thank you, Rachel. Yes, so there are 24 states that have 1115 Medicaid waivers. There are another 9 in the pipeline right now, pending more waivers. One of the 9 is New York State, and it's expected to happen this year before the calendar end of 24. So
For
we've been
SUD
working
or SMI or both?
both.
Okay.
So we've been working with New York State, and this week I've had numerous meetings, Zoom meetings with people in New York State who face the same dilemma that you just described. And we are working to do with them a project in Albany, New York, which will fit somewhat, almost exactly what you described. And I think that's going to be the first one of that nature that will be done and open in terms of the solution that you gave a great description of. In terms of the county funding, we actually have talked to Synergy. We went up to Sacramento, so toured their facilities, met with them. We haven't been able to match up with them right now with a facility. They happen to be 90% complete with a facility they were working on already. They needed expansion of another facility that wasn't exactly the same description that you gave. So when the time is right and the conditions are right, we think that's going to be exactly what you described: county funded, Medicaid partial funding. The county situation, I think, is a big part of our future. Here at Turner, that it will be part of ours, what we do.
So once I knew the Synergy people, I think I introduced Len to them, and I was very hopeful. But they have so many projects going on currently in Northern Cal. I am hoping that they would expand into Phoenix, because we hope to get some secure berths or just a lot of berths built in the Maricopa area, because we need so many right now. And the other one, there is another one in New York, Len. It's called Hope House. It's going to be in the Bronx, and it's Francis Greenberger, the Greenberger Center. So I met Francis many years ago. They've been working on this for 8 years, but they did break ground, and they ran into some building issues because New York is a rock, but it should be open in 2025. And then Dawn, you had your hand up.
Sorry, yeah, let me see if I can lower it. Okay. Yeah, I wanted to just say I applaud New Freedom, because our son did go to New Freedom. He did really well over there. 3 months. He did have housing and a job after, but with him, we figured out, from him being in New Freedom, that was the kind of support he needed. So he kind of fell afterwards, after kind of struggled along after the housing. But they did give him housing. It was in a regular sober living. There were special needs people in that sober living though, and a job, and he had transportation with his job. So it was a great experience for him, very positive, but still the housing, and I've heard a couple people that have finished that program, that the housing piece, when they finish, they do sometimes they set them up, but it just depends on, is it an appropriate setup?
Yeah.
So yeah, that was, I mean, we're just learning with our son for sure. He's in his 20s, so it's like we're like stumbling along. But let's see. What's the community health center that was affiliated with them? Because do you know? I guess I could call them and ask them.
Yeah, call New Freedom. I don't remember the name of the community health center, but they'll know what you're talking about. It's within a mile of the facility. I think it was something like 10 blocks away.
Okay.
But Dawn, you made thank you for your comments, because you reminded me to talk a little bit about something we didn't mention yet. In the housing world, we are experimenting with something that is really interesting, really unique and innovative. So there are mission-driven people out there who came to us and said, you guys put housing, affordable workforce housing, in neighborhoods where we know there are people who can't get healthcare coverage, behavioral or physical. They can't afford it. They fall through the cracks because they don't qualify for Medicaid. And what do we do? So they came to us and they said, what if we built a system for housing and healthcare where the landlord incorporated in the affordable rent a per member per month, per family per month fee, which gave every member of the family in one of the housing units that you built and people were living in unlimited access to primary care. And the cost that it could be done for, you pencil out all the numbers, $35. $35 per month, unlimited access for any member of the family living in that apartment for primary care services. And what that means is physical and behavioral. So this problem that I know everybody is thinking of housing access and the drop off of access to physical health and behavioral health services after like for instance, 90 days at New Freedom, you kind of kill two birds with one stone. So we looked at it and we think we can do it. It's just a matter of ironing out the nuts and bolts of being able to kind of structure it so that the rent doesn't have to go up. The $35 is paid in the rent. It's not an additional thing that the family has to pay. And the landlord, as a landlord, can still be sustainable and financially stable because that you're offering leads again to longer, solid, no turnover, right? You're further extending the ability to increase longevity of a given tenant family, and the landlord therefore is saving what it would cost to do a turnover of that unit, and the rent is enough to make it work. So I hope that made sense, but it's kind of looking at what Dawn described as the challenge once they leave a program like New Freedom, but the whole challenge of continuing access to behavioral health services, physical medical coverage that keeps going, and affordability. The model, in case anybody wants to look up direct primary care, DPC. It's based on this whole DPC model where you cut out a lot of the wastage that's there now. DPC is all about value-based per member per month payments, and that the primary care practices who sign up to say, yeah, I can do that for $35 a month, that they will be available, they will be tracked for performance, they will be measured, they have to report their metrics, so it's high quality, but that they can do that, and it's working. DPC is working. We need to figure out how to kind of get it into the connection with the rent from the landlord and work through the state insurance rules and all of that kind of thing.
And I just have a question about that. So say there's, a family living in one of these units and they're paying $35 a month within their rent. I mean, the philosophy is perfect. And it's exactly what families need to be able to jump from being on Medicaid to having commercial insurance, and then also being able to afford copays and everything else. It's that the idea is perfect. So I guess so that would be on top of a commercial insurance, and it would be just to cover those. I mean, having unlimited means I don't have to pay, copays for, therapy. I don't have to pay copays for primary care. I guess I don't know if I have a question. I'm wondering how those financials work out, because I'm just like, why is there not more of this? And the payoff, I guess, is that we can collect that data and show that having this assistance during that gap of time between Medicaid and being able to afford some of those other, costs, having that, it really helps people into a better life, creates better community health. Is that kind of what I'm hearing?
Yes, absolutely, Jesse. So the idea is anything that will work to increase the average length of tenancy is looked at by the landlord as, hey, I want to house those folks. I want to have them as my tenants, because with that cost of $35 coming out of the rent I'm getting from them, which I did not increase when I gave them that benefit, I'm getting $36 worth of extra longevity and lack of turnover costs because they're staying longer as my tenant. That's the kind of idea. Within
Yeah.
the DPC model, $35 is, I know it's crazy for everybody to think about, but when you have strong primary care, $35 is enough to make a going concern of a high quality primary care access to families that need it for so much of what they need. When they need something beyond that, there's going to be people who get into a car accident and need trauma care way beyond the $35. But that becomes, things like catastrophic insurance coverage. But the fact that you have access to a family physician, a pediatrician, a psychosocial masters of social work, family service counseling, psychiatry access inside of that with no copayments. You said it beautifully, that you don't have a copayment every single time. The DPC practices forge relationships with the other services that people in the family will need. So they kind of beat the problem of, well, I can give you primary care for $35 unlimited and it's fine. And if, you're sick every day and come to see me 30 times, once a day, every day of the month, it's my sweat equity. It's my sweat invested in it. I'm not paying somebody else as the family doctor. I'm doing it myself. I'm working harder for the $35, but on average, big numbers, when you kind of look at the averages, that's what the cost is being, it was started at 30 and then looking at the reality of post-COVID world, it went up to 35. But it's a interesting, really beautifully conceived model that addresses so much of what's kind of broken in the fee-for-service volume-based healthcare world.
Yeah. And for the landlords, that flips the idea of lower income tenants as well. You know, that becomes possibly the demographic that they're looking for in this type of model, obviously, versus you know, what most landlords are cherry picking at this point because they can, because of the housing market. Do you think that it will have any, you know, this at a larger scale will have significant impacts on the housing market? Does you know, your group of people take a look at that as well too? Or is that a driver, or is that just sort of something that may happen on the side?
You know, it's a great question. I think back to visiting kind of beta test sites for housing. We looked at one, was trying to put all the pieces together that you and I have just been talking about, and what we've really been talking about for the whole hour. We went and visited a site that was the very first in America jurisdictionally approved in terms of sound, environmental quality, fire retardants, all these things. The entire building was made of a special kind of plastic. And the ability to build units quickly and inexpensively with material that was so different than anybody's thought about with building material. They hear plastic and like, I hear plastic and I say, oh, wait a minute, the world has way too much plastic. But if you're building a permanent structure and it's made of plastic and it's got better fire suppression than the typical materials we use now, and it does, tensile strength because of what it's a special kind of plastic, quick to make, modular, sound. We visited one that was literally next to a freeway, and you didn't know there was a freeway there. It was the sound blockage was incredible. So think about combining that into this whole model and the ability to have cost per door, we call it, cost per unit for a family to have an apartment, you know, half, a third of what we all see quoted in when jurisdictions try to do, you know, Maricopa County tries to build housing, it comes out to $700 a door. It's like, how could it be that much money? Why is it that much money? You know, some solutions as we think through all these things. Just kind of you get these challenges and you face them and you just try to work through each one.
Miriam, you have your hand up.
Hi, I too want to applaud you. This is very. I wish you were running for president. We need more grassroots.
Don't wish that
activists.
on me, please.
This is hope, and we need that. And you know, I'm just so thankful to hear this. My mind just wandered off to the capsule housing that I follow on TikTok. That wasn't really my question, but that was, you got me thinking about that, because I know they're the price. They're like $10,000. These capsule houses, they're like spaceships. I mean, they have everything you need, high tech. They're gorgeous. They can put them up fast. I mean, there's so many incredible possibilities with housing and maybe even home ownership. If it's only like $5,000, why don't we throw some capsule houses together? And you know, that wasn't my question though. My question or comment was, one, to thank you, and then also you really had me thinking about Eleanor Roosevelt and some of the housing projects that were created in World War II, and also some of the World War II you know, like they'd have not soup kitchens, but community kitchens. I lived in old World War II housing for a while. I was a Navy wife for many years. I gotta say, I miss that healthcare so much. And people don't realize how much it is like socialism, but it is, because you have everything right there, no co-payments, and it's free. And, you know, and I also want to say, I've always felt that poverty was the number one factor in causing mental health. Poverty is a mental health illness. Poverty. And, you know, I wish that we would have focused more on the war on poverty instead of the war on terrorism. Whoever somebody decides a terrorist could be anybody. You know, we're mad at this person, so they're a terrorist. Let's kill them. Anyways, that's my politics. I don't want to get into it. I know it's touchy, but the poverty mental health connection my son as well has had mental health crisis and a breakdown. He's a college graduate, but he's Black, and he ended up arrested, and now he's in the system, in and out, but he has a breakdown. And I'm really thankful to you for hearing about, I don't think it was called New Freedom. And I've dedicated my life, a lot of it right now, to helping people who are inmates and treating inmates like humans, giving them voting rights, ones that have them, and also treating, helping them transition out. Because, whether it's through Buddhism and giving them stuff to read or college education. And it's been so hard for my son to stay. Housing's been big. So everyone's right about that. But also just not being restricted. Okay, you can't use a cell phone, but you have to have a cell phone, but it has to be a flip phone. Oh, look, we can find for $70 a month, you can get a Gab phone, but he can't even use the technology he used in jail, which was so helpful for him, such as the inmate tablet. He's not allowed to have that, so he can't go to meetings. He can't use all the resources and go to school. He's just kind of stuck with library books. Yeah.
I hear you. I hear you.
Yeah. Thank
you.
Guys,
Oh, you're welcome. Thank you for your comments. But I got to tell you, when you mentioned Eleanor Roosevelt, World War II, and housing, when I'm probably going to give away my age, but when I was a little child, my family moved to Levittown, New York, Long Island, New York, which was one of the first World War II, end of World War II, big housing complexes. And we moved there from the Bronx, New York City. And when we got there, my father looked at the whole thing and he said, and he was a deli man. He was a food person, right? Feeding the masses. But when he looked at Levittown and where we were living and what was going on, there was no space in those small homes for washers and dryers. So he opened up laundromats so people had a place to go do their laundry. It was,
I love it. Yeah,
thank you for reminding me.
My sister lives in I think it's Glenview or Glendale. I can't remember, but it's one of the first ones that's in Maryland. It's a walking town, and it's still there, and it's weathered this, the time. The concept is still great. It's unfortunate that just didn't continue because the one stop, where you have the grocery store you can walk to your being able to walk is imperative. So if you can walk to, one, for exercise, but two, to healthcare, you can walk to your support systems, the less that we have to depend on transportation and getting far away. And also I want to say, I go to Oak Street Health, and I'm new to it.
Okay.
It is, yeah, I have PTSD, so I've gotten my SSDI early. But it's interesting. I just started it this year, but it's there's a lobby.
It is.
There's,
we
I like the support, though, the bingo, and they have karaoke. I need to try and get more active.
We built 6 facilities for them.
I'm in Apache Junction, so that one. I just bought a home here in Apache Junction, or a condo, and I love it. I want to get away from Maricopa. Thank you. Get me out. But yeah, I love it. Thank you so much. Bravo.
You're welcome. Thank you for your comments.
Oh, Jesse, you have your hand up. Sorry, I was on mute.
No worries. Before working for Spectrum Healthcare, I actually worked for a nonprofit that was doing work in building affordable housing and trying to transition people out of homelessness and into housing. So I have a little bit of background, and I'm wondering, one of the biggest concerns when we would try to open a new site would be that the people in that area would be very concerned about crime. And do you guys have any stats on that? Have you had instances where there are neighbors that are having issues with the folks that are living within the housing that's being created? Anything on that subject?
Yeah, absolutely. Thank you for reminding me. When we build the enrichment centers in the housing complexes, one of the big components of the curriculum is safety programming. So first of all, we put in every site, we put 2-way audio and video cameras around the campus, monitored 24/7, 365 by people, not artificial intelligence, real people. We have one of our key people in our team here at work is someone we call our Secretary of Defense. He's a former Marine. He is a former SWAT officer. He is an amazing, amazing person. He heads up all of that kind of technology assisted with cameras and sound. So, if something bad is going on, there's people watching somewhere and they have the ability to push a button and talk to the bad guy and say, I see you and I see what you're doing, and police have been called. And when they say police have been called, well, some of the programming in those enrichment centers is offered by local law enforcement, and they live with their families on the property. And when they do that, they agree to park their squad cars on the property. So they help form community watch. They help do perimeter safety control teaching, safety in the community. They do, all of that translates into such a much better than what was going on in the first place where these things are. Best story I can share with you, Washington, D.C., Ward 9, I think it was, there was a housing complex that was in that section of the city where we were building a charter public school. Across the street from that charter public school was this housing complex. That section of the city had the worst murder rate of the entire United States per capita. We got there, we built the school, we got the community involved. We went into the housing part of across the street, got involved, got our programs going. In 1 year, the murder rate had dropped like 63%. 2, 3, 4 years out, became one of the safest parts of that part of the city you could live in and around. So there are solutions. We just have to think creatively, bring to bear these forces that make a difference in people's lives. The ownership of the community by the good people that happens when you give people opportunity and access and caring is amazing. The things that change so quickly for the better, it's amazing. Just turns 180 degrees.
One other question sort of on that note, evictions are obviously handled by the healthcare company as the landlords, is that correct?
So
If
interesting.
necessary.
Yeah, good question. Thank you. You guys are asking great questions because it's reminding me to talk about something I didn't get to. So we have an in-house division of our company called Turner, TI Properties. It's our property management division. So we do it all ourselves. We didn't want to keep farming it out. You can farm it out and you can save a little money, but the heck with that. We're going to do it ourselves and do it right. So that division handles a lot of what's going on when people run into trouble, can't pay their rent. What do we do? I am happy to share that in an era when COVID hit and we were worried, and a lot of housing operators around the country were seriously in trouble with evictions and occupancy rates that were bottoming out. I think in only one of our properties, remember we have 11,900 units or 10,900 units, only one property dropped below 90% occupancy. And that was through a lot of work, a lot of effort, a lot of input from our people in TI communities. They're on site, they're working with the tenants. I can't tell you how different the relationship is between the tenants and us being the landlord than what you typically think of and see. It is absolutely upside down compared to what the bad situation that happens in most places. And it makes a difference. And remember I told you about financial literacy programs in that enrichment center? What we're doing is working with every tenant and then them understanding what goes into their credit scores and how to deal with credit card debt and what to do about all things financial, and understanding that and it makes a huge difference in people's lives and how they live day to day and what they do when they bring home their paycheck. And when no more than 30% of the rent of the take home pay is going to rent, it makes a difference when you teach them how to teach everybody the better way to do things. I mean, I've learned from those programs, just sitting in on them on the Zoom sessions. So, all that put together, of course, there's always going to be eviction issues. It's going to happen. We handle it the best way we can. We have that internal division that we work with day and night to make sure that's done the best way possible. But the overall rate of that happening extraordinarily low, with considering where we are, what communities we're in, what part of the communities. So
Thank you.
I was just going to ask if you often have, or if you provide legal counseling or assistance if they have an eviction notice. I mean, since you are the management company, do you arrange a sit down to say, how can we go, how do we move forward from here and not get evicted? What can you
absolutely.
do differently?
Absolutely. I had some family members who had problems when COVID hit with eviction issues. They had property that they were the landlord in Chicago, and the situation was resolved for everybody's betterment by the folks who I knew from the internal workings of our company, who helped my family with how to deal with the tenant problem that it was my daughter-in-law had in that setting. And it was a good example of the skill set and teams of people we have, legal included, to sit down with, if there is a problem, the landlord tenant situation. Absolutely, yes. The answer is yes.
So Len, this has been great. Does anyone have any other questions? And then if not, you're welcome to stay on, but we usually transition and see if anyone needs any help with any particular situation that they're having with the behavioral health system. So you may want to, we only have another 27 minutes, but you may want to listen in to see what kinds of issues some of our families are facing.
I would love to. I appreciate the invitation, but they're going to throw me out of this building if I don't hang up and leave. We start at dawn every day because of East Coast work. So I'm getting dirty looks from the cleaning crew and the security people.
Okay. Thank you very much,
Thank
Len.
you so much.
Thank
sure
you,
hope
everybody.
I hope you expand your footprint in Phoenix.
We are working hard to do it. I'll let you know, Lori, when the second New Freedom opens. It should be in a matter of a few weeks.
Oh, that's great. Would love to go see it.
All
Thank
right.
you.
Thanks, Len.
Thanks. Thank you. Thanks. Hi, Ken.
Hi.
Thanks, everybody.
Thank you.
You.